interest, and the learning objectives of my speech are to identify. So, my topic is varicocele embolization, and I have no conflict of interest, and the learning objectives of my speech are to identify the indications, results, and outcomes, to demonstrate the anatomy and the mechanism of varicocele treatment, and to define their complication. Varicocele is an abdominal enlargement of the pampiniform plexus caused by reversible blood flow or impaired drainage of the testicular and internal spermatic vein, and is found in up to 23% in young healthy male individuals, up to 40% in patients with male factor infertility, and in a range between 75 and 95% is left-sided. We have three main etiological theories. The first one is related to an insertion of the left inferior spermatic vein into the left renal vein. The second one is the lack of functional valves in the spermatic veins, and the third one is the retrograde flow secondary to the compression of the left spermatic vein between the aorta and the superior mesenteric artery. Varicocele can cause adverse effects and spermatogenesis damages because of a higher testicular temperature and intratesticular pressure, and this leads to hypoxia due to attenuation of blood flow, reflux of toxin metabolites from the adrenal glands, and increased oxidative stress. In 2023, the Standard Practice Group published this paper, and they stated the pre-treatment evaluation, history, physical examination, duplex ultrasound, and semen evaluation in subfertile men. Of course, clinical evaluation in supine orthostatic position and after Valsalva maneuver. This is the battery of hormonal test. And regarding the ultrasound, regarding the diagnosis test, a scrotal ultrasound is recommended in all patients and is especially useful in cases in which physical examination is inconclusive. Furthermore, US, in particular Doppler ultrasound, appear to be the most reliable and practical method for diagnosing subclinical varicocele, and of course, in subfertile men, semen analysis should be performed. Doppler ultrasound sensitivity of 93%, specificity of 85%. We have several scores, in particular two: the Chu scoring system and the Sartesky classification that is mainly used. What about the indication? That is the basic point, the topic points. Indication: palpable varicocele, testicular pain varicocele, to prevent or reverse testicular atrophy in adolescent males, coupled with infertility, one or more abnormal semen parameters or sperm function test results, elevated sperm DNA fragmentation, and to improve testicular function in hypogonadal men. So we have three areas. We have one area, yes, treatment indication, pain, azoospermia, and coupled infertility. One debate regarding the treatment, the simultaneous treatment of bilateral varicocele and indication, the precise indication in pediatric and adolescent patient, and no indication for subclinical. What about the coupled infertility? We should have clinical palpable varicocele, oligozoospermia, infertility duration of more than 2 years without any other cause of infertility. This is a very useful flow chart that was published in 2023. Infertile couple, male partner with varicocele, female factor, of course, absent, abnormal semen analysis, grade 2-3, treat varicocele. But also in normal semen analysis, we may have elevated DFA, DNA fragmentation, so we have to change lifestyle. Of course, we can go on with the treatment. What about varicocele and azoospermia? We have to reply basically to three questions. Is it permanent or transient? Obstructive and azoospermia to varicocele or to coexistent primary testicular failure? And this is a very useful schedule to make a differential diagnosis. And furthermore, regarding the azoospermia, we should advise our patients that in case of azoospermia, the result of our intervention is 1/3. What about bilateral subclinical? In urological literature, they said use simultaneous the right and the left, and not to treat subclinical. We don't use to treat bilateral varicocele, and we don't use to treat subclinical varicocele. This was also assessed by several guidelines of several societies. What about varicocele in children and adolescents? We should follow, of course, the guidelines, but I have to say that only one guidelines fixed the right indication, because The ESPO guidelines say that testicular hypoplasia is the indication, the main indication, and testicular hypoplasia means test is smaller by more than 2 milliliters or 20% compared to the other tests. And they give also other indication, varicocele associated with small testes, of course, bilateral palpable varicocele, pathological sperm quality, of course, in older adolescents, symptomatic varicocele, but they also say that maybe we could repair large varicocele physically or psychologically causing discomfort. Of course, other varicocele should be followed up until a reliable sperm analysis can be performed. So we start with our treatment. Venography is considered the most sensitive diagnostic test, and we have two approaches. We have the approach transfemoral, transjugular, transbrachial from above. Transfemoral, right femoral vein is the most common, but we need to reverse to the curved catheter. Transjugular, transbrachial, we have the possibility, a higher possibility. Which vein in the arm? I should suggest the basilic vein, because the basilic vein most frequently means good condition in terms of diameter, distance from skin surface, and path of travel. As, of course, the arm approach have the high compliance from patients. We have a classification. The Barren one for the last side is most used, and the Siegel classification that was published in CVIR in 2006 is the main one for the right side. So we have a lot of retroperitoneal collateral that must be taken count because it can be the cause of recurrence, and also collateral symptoms. For example, the axillolateral retroperitoneal collateral vein to the colon may be responsible for colitis after sclerosis. And of course, the transscrotal collateral maybe is the reason why we don't use to perform the right side sclerosis in case of bilateral varicocele. So we have to exclude nutcracker phenomenon or symptoms, and the nutcracker is the stenosis of the left renal vein between the superior mesenteric artery and the aorta. This is responsible, also called aberrant varicocele, with specific phlebographic appearance. Sometimes we have a competent proximal valves, and we have such kind of congestion with such collateral that feeds the distal portion of the left spermatic vein. So we may have such congestion, we may have so normal appearance of the proximal portion of the left spermatic vein. Could we consider stenting? Stenting is off-label. In the left renal vein, stenting for varicocele is off-label. For this reason, I say we may distinguish nutcracker phenomenon from nutcracker syndrome. In syndrome, maybe we can have some kind of indication. In nutcracker phenomenon, we don't have indication. And the Standard Practice Committee evaluated the literature from 2006 of more than 1,000 patients. The results, we have the results, the resolution. We can relieve the orcalgia in up to 100% of cases. Regarding the post-procedural pregnancy rate, maybe it remains uncertain when any treatment compared to no treatment is in subfertile men may be of benefit to live birth rates, and macroscopic subinguinal surgical treatment probably improves pregnancy rates. Regarding the semen parameters, several studies have shown significant improvement of semen parameters following varicocele embolization. However, it remains uncertain if this is correlated with increases in live birth rates. And catch-up growth of the testes, several studies have reported testicular catch-up growth after treatment in 60 to 90% of boys. So these are the recommendations of the SOAP. Regarding the embolization started in 1979, and nowadays we have three main types of embolic material. Absolutely personal choice. There is no evidence that one material is more effective than another one. Some tip, for example, for coal, we have to reach the distal portion, the spermatic vein, and we should reach the region of the collateral. For the glue, we have to try to inject the glue while withdrawing the catheter, but of course, some expertise is needed. And regarding the sclerosis injection, maybe it's useful to use a bundle-occluded technique because it allows us to determine when the pelvic varices are completely filled by the sclerosing agent and avoids systemic dispersion. When we use the occlusing balloon, we stop the flow distally, proximally with the patient can push, or you can use also a rubber band in the external pelvic ring. In this way, you stop the flow, and you no need for foam, you no need for Valsalva. There is a maximum concentration of sclerosant, less expensive than coils, less complication. What about complication? We may have immediate or delayed. Immediately related mainly to the embolic material that we are going to use. For coils, we can have migration. For glue, the same. We can have vein rupture when we catheterize the spermatic vein, and when we have vein rupture, the use of sclerosant agent can be avoided because we can burn the ureter if it's closed, and the delay complication, phlebitis, and coil migration. There is also the dark side of complications that are not so common, very, very rare, but we must be aware of this. For example, hypersensitivity to nickel. Every coil we use have nickel. So the problem is that when we have one patient, it's very rare, but when we have this kind of complication, one in our life, we don't use coils in varicocele anymore. And also for sclerosant, there is a suggestion to use foam, but with foam we have hair, and with hair we can have such kind of complications. So if it's possible, not use hair. Regarding the comparison between surgery and vascular treatment, the standard of practice papers say that the main advantage of radiological treatment are very low risk of postoperative hydrocele. We should consider that in surgical series, in particular in Palomo series, the hydrocele reach the 30% of patients. And the low cost and the possibility to be performed under local anesthesia. And because many papers still are not giving an issue regarding the comparison between the vascular surgery. This is the Cochrane database. It was published in 2021. More than 5,000 people, 5,000 men, and they try to do some kind of comparison, no evidence for anything at all. And this was suggested and confirmed by the last two meta-analyses, one of urological literature and one of radiological literature. Current data does still not support the superiority of one type of treatment over the ones. So in conclusion, percutaneous embolization of varicocele is an accepted treatment. No, it's an assisted treatment because it can be the fast and the less expensive, and this is related to technical implementation, and it can be also the less risky and the most effective. And this is mainly related to good selection on patient, clinical skill, follow-up, and scientific methodology. Thank you for your attention.
Thank you for... Any question from the audience? No question? I have one question, Antonio. What is your personal choice for doing this approach and materials?
Well, I want to say the less invasive access, the brachial access, because we are treating people that mainly it's the first time that they're approaching in an hospital. They are very young and they are very scary. And so this is the less invasive approach. And also I use the less expensive and most effective agent, the sclerosing agent, with the balloon occluding technique. So I don't use coils because I had one problem with the nickel hypersensitivity. It's very rare, but of course, if you can have the same results with the less expensive agents and less risk, that's it better.
Local anesthesia, just local?
Yes, yeah. Local anesthesia.